Well, it's mostly in the field of cornea transplantation where there's been a revolution, and from transplanting tissue we're now looking at transplanting cells, and we will be, for example, maybe in the next 10 years not doing endothelial transplant anymore. Thanks to the work of Professor Kinoshita, we might be transplanting cells. But for me particularly, I'm most excited about this predesmous layer we discovered in the cornea about 3 years ago, and its connection with the trabecular meshwork. So the implication for glaucoma are immense. It's an area of research we are now undertaking in our department, and if we can approach the whole problem of glaucoma from a different angle, that will be really new in the field, and that's what we're really excited about. Yeah, it's cornea and ocular surface sessions, and again, the different techniques of cornea transplantation. Personally, I have an interest in teaching and education, so sessions where you can impart skills and knowledge to the juniors, that's been exciting. And there are a couple of satellite sessions which are very focused, so you also learn from the other speakers. I was interested in those. Young ophthalmologists from Europe particularly, that they are at the moment more concerned about their training, and the training standards across Europe are very variable. I might venture to say that the highest standards are in the United Kingdom. We have a very structured training program over 7 years. Europe is a more truncated 3-year period in most centers, and many of the countries don't have a national qualification. We have the FRC OFT in the UK. But my message to them would be to avail all the training opportunities across Europe, to bring as much pressure as a body on your peers and on your trainers to give you more surgical training. And once you've acquired all that, just broaden your vision beyond Europe to parts of the world where the trainees have even less than what they have here, and to try and help them in any way they can, particularly in Africa and some parts of the Middle East where the training standards are quite poor at the moment. The symposium was on ocular inflammation, particularly ocular surface inflammation, and my remit was to look at some of the diagnostic challenges. And using dry eye as a model, I was able to show that we don't even have consensus on what to call it. And there are about half a dozen, maybe more, terms used to describe the same condition. We're not quite clear about the symptomatology because there's a huge overlap with other diseases, and specifically the diagnostic tests that we use for dry eye, the overlap between normal and abnormal is great. So we haven't been able to come up with a test or a combination of tests that can give us a more definitive diagnosis. But the greatest point I made there was that we are making a mistake in calling dry eye as one disease. I think it's a basket of diseases, and the analogy I gave was that of glaucoma. In the past, we all thought glaucoma was one disease, but we know now it's not. And the same for dry eye, it's not one disease. For example, the dry eye that you get following keratorefractive surgery cannot be the same as the dry eye you get postmenopausal women. So, and the one in rheumatoid arthritis, for example, a systemic disease associated with dry eye. There are different things going on, and our approach to management has to be different and not lump them all under one condition. So I think those were the challenges that we need to confront.